My name is Ram Srinivasan. I'm the clerkship director for RadClerk, and I'm here today with Ashley Komu. Ashley, you've just finished the RadClerk rotation, including both chest and MSK rotations, and thank you so much for meeting with me today and getting a chance to share with everyone else out there what you learned during the rotation. Let's just go ahead and do some cases. Tell me about this patient that you're looking at here.
We have a 15-year-old child with a sudden increase in oxygen requirement. So we always want to make sure it's the right patient and the right radiograph. So just check the name and then it's the right study, date and time that you want. You want to make sure that the radiograph has been taken well. So check the adequacy of the technique, and then you want to check the pathology as well.
So what's your acronym for figuring out adequacy of technique?
So we use RIPE-F. So it's rotation, inspiration, projection, exposure, and then field of view.
With rotation, what are you looking for in terms of landmarks that tell you if the patient is rotated or not?
So the landmarks would be the clavicles and the spinous process. So you just want to see if there's any overlapping between the clavicles and the spinous process of the vertebrae.
Great. And here it looks like the spinous process is centered on the clavicles, so they're not rotated. Inspiration-wise, what are you looking for?
So you're looking for lucencies in between the ribs, so you want to make sure there's at least 8.
Okay, and what do you think about the inspiration overall here? Is it low, normal, or high?
It looks low. So you can see on the top there it says portable, so it would be AP. So AP is anterior to posterior, so that just means that the x-ray is moving from the front to back, so anterior to posterior. So AP will make the cardiac silhouette look bigger, so it's important to know, is this cardiomegaly, is it in a large cardiac silhouette, or is it just AP?
How do you look for an over-penetrated film specifically?
So I would look at the lung spaces, see if there's any blacked out areas that you can't get out of when you're windowing and leveling.
Okay, and for under-penetrated, what do you look for?
I look at the intervertebral disc space. So if it kind of looks like a blob of white, then it's under-penetrated.
The field of view, is it adequate or inadequate?
I'd say it's adequate. You can see the base of the neck and then the upper abdomen, and you just want to make sure you can see both of the costophrenic angles. So I'd say it's good.
Awesome. What acronym do you use to assess pathology?
So you use the ABCDE acronym. A is for air, B for bones, C for cardiomediastinum, D for diaphragm, and then E is for everything else. For air, you're looking at the airway, the air spaces, and then the vessels that traverse through them, the pulmonary arteries. So I would start with the trachea. So you just want to make sure that it's midline. Here you can see the bronchus stem off here, and then you can kind of follow it back, and I think the carina is right about here. The upper lobe on the right side, you can see there's something going on there. So it could be a collapse there, like a mucus plug causing that. It could be consolidation. So you can look down here and see, oh, there was actually a previous here. So you can see the current here on the left, and you can see this consolidation here. If you look at the previous, you can see that it's clear. So it seems like a relatively acute process, so that can help you in your differential. This is a line placement radiograph that is just more suitable to helping you see the lines. They're just easier to differentiate on this. Those are electrocardiogram leads. We can see an ET tube here. So there's a little tool over here so you can measure to make sure that it's the appropriate length that you would want. You can see it's about 5 centimeters. This line here, it looks like a right internal jugular central venous catheter. So it should be in the cavoatrial junction, and by rule of thumb, it's 2 vertebral bodies below the carina. The tip is right about there, so I think it's in good placement. You can see there's a little kink here.
Great job with this case and great job with the rotation overall. Let's move on to the musculoskeletal case that you have, the pediatric elbow.